All right. So for the next calcium channel blocker, I've told you guys a hack of remembering all these calcium channel blockers. Anytime you see a drug having dipine is simply what a calcium channel blocker. All right. So we get to look at what nimodipine, the pharmacology of what nimodipine. Now, in this nimodipine, we get to look at the overview of the drug. We look at the mechanism of action of the drug. We look at the pharmacokinetics. We look at the clinical uses. We look at the safety and side effects when using this drug. Okay, nimodipine. All right. So for the overview, we said that what nimodipine is a calcium channel blocker. All right. So calcium channel blocker is basically a drug that will block calcium channels in probably blood vessels or smooth muscles. So it will not prevent the calcium from coming in to cause a contraction. You get? So it's what? It's a calcium channel blocker that is used to improve neurological outcomes in patients with what? Subarachnoid hemorrhage due to a ruptured intracranial aneurysm. Okay? So let's look at the mechanism of action. Nimodipine works by what? Blocking calcium channels in vascular smooth muscles. Alright? Particularly in what? Cerebral arteries. Okay? Can block elsewhere, but particularly in this. Okay? So it inhibits calcium influx. So therefore, calcium will not be able to come in and cause a contraction. So therefore, the opposite will happen, which is what? Dilation or relaxation. Okay? So this will lead to what? Vasodilation and improve blood flow to the brain. Okay? So it stabilizes what? Voltage gated L-type calcium channels in their inactive conformation. Alright, so this will prevent what? Calcium dependent smooth muscle contraction and subsequent vasoconstriction. Okay, what is the pharmacokinetics of this nimodipine? For absorption, this nimodipine is well absorbed orally, okay, with peak serum levels reached within about 1 hour. Right? Metabolism, it undergoes extensive hepatic metabolism via the action of what? Cytochrome 3A4. Okay, excretion. The drug is excreted primarily in the urine. All right, less than 1% of it as unchanged drugs or feces. Okay, half-life. Elimination half-life is about 1 to 2 hours, but it can be prolonged in patients with renal impairment. Protein binding, nimodipine is highly protein bound. About 95% of the drug is bound to plasma proteins. Okay, clinical uses. This drug is mostly used in what? Subarachnoid hemorrhage. So it's used to reduce the incidence and severity of ischemia deficits during subarachnoid hemorrhage. Okay. For cerebral ischemia, it can be used off-label for treatment of focal and global cerebral ischemia. Right. Then for safety and side effects, for common side effects, it can cause hypotension, headache, nausea, and dizziness. For contraindication, it's not to be administered intravenously or by other parenteral routes due to the risks of what? Serious adverse reactions that the drug can cause. Precautions. So given the drug, monitor for potential interactions with other medications that could be metabolized by what? Cytochrome 3A4. Alright, so for conclusion, say that this nimodipine is a valuable medication for managing cerebral blood flow and improving neurological outcomes in specific patient population. Alright, so that's it for the pharmacology of what? Nimodipine.